Okay. Good evening, ladies and gentlemen, and a very warm welcome to Henley's River and Rowing Museum. This is the 9th of 15 planned meetings of the big health and care consultation, the Oxfordshire Transformation Programme. My name's Gavin Gray. I am not part of the panel. I do not work for the NHS. I'm just chairing the meeting as a freelance journalist. In fact, I used to live in Oxfordshire, and my memory serves me, may even have reported on the very opening of this building for ITV at the time. So it's lovely to be back. It's my role here, and it's a smaller meeting than usual, but that doesn't make it any less important, and equally, the role of the meeting and my role remains the same, which is to get as many voices heard tonight as possible, questions, concerns, suggestions put to the panel, and to get answers to those. And we're going to do that in a couple of different ways. I'm going to ask the panel shortly to introduce themselves. Then there will be a short presentation. And I don't think it's going to be terribly long. There's a little bit of video in it. That'll outline some of the proposals regarding Henley and this part of the county. And then we will have a short questions and answer session. And then what we found very useful in a couple of other areas, good evening, is to have a sort of breakout discussion in different tables. And that way, people who are slightly less inclined to actually get up and ask a question, as it were, with the rest of the audience in mind, may feel a bit easier to mention and ask their questions in those smaller round table groups. And then we'll have a concluding session. We have got the room through until 9 o'clock, but obviously with a smaller group, if we don't sustain until 9 o'clock, there's no point in just keeping it going until 9. So 8 till 10, 2 hours. But we'll see how we go. I'm on a different time zone already. Okay, just a couple of housekeeping points. No fire alarm practice is planned. So consequently, if the fire alarm does go off, it is genuine, and there are some doors just round to the side there, at the back, and also round to that side, and we meet towards the river. Not that we are expecting any. If you've not found them, the toilets are effectively through that wall, and you get to them by going through there and left and left. It is obviously a no-smoking building. If you've got a mobile phone, it would be great if you could switch it off or to mute. This is a public meeting. A recording of it is being taken, so notes are being taken as well of what is being said. And as you may already know, on the website of the CCG, the Clinical Commissioning Group, audio of the other meetings has gone up onto those as well. But this is your opportunity to get your opinions and ideas heard. If anybody needs it, there is an audio loop that is also available for those who might want that. So as I mentioned, that will be the schedule, and it'll finish with some final summaries, but a good opportunity for people to ask any questions that they want. I'll get the panel to introduce themselves first of all. We'd better start ladies first. Sula.
Good evening, everybody. My name is Sula Wiltshire. I'm the lead nurse for the Clinical Commissioning Group. I've lived and worked in Oxfordshire since 1980.
I'm Andrew Burnett. I'm a GP from Sonning Common. I'm also the Clinical Locality Director for the South East locality of the CCG. That means I chair a group of the 10 local practices. I've been a GP around here for some time, so it's very exciting to be part of these proposals.
Thank you, Andrew. And another Andrew.
Good evening. I'm Andrew Stevens. I'm the Director of Strategy and Planning for the Oxford University Hospitals, a job I've been doing for the last 17 years. We run the 4 hospitals, 3 in Oxford, so the John Radcliffe, the Churchill, the Nuffield Orthopaedic Centre in Oxford, and the Horton Hospital in Banbury, as well as a number of associated community-based services. We're obviously conscious on the panel that the population in this area looks to the Royal Berkshire for a number of its services, although a number of you will also use our services, particularly in relation to specialist services.
So there's your panel. We have, as you see, the right people to talk to regarding Henley and the future of healthcare. And I know that Sula just wanted to kick off with the start of the brief presentation, and we'll then hand over to Andrew. Sula.
Thank you very much. And as Andrew has said, it's important to we do recognise we're in the south of the county, so some of these changes may not seem as relevant to people in this locality, but it's important that you understand them in the whole, because you are part of Oxfordshire's clinical commissioning group, if you like, because of where the GPs are linked into the clinical commissioning group. So I hope that makes sense to people. Thank you. Next one. Thank you. So the consultation has started on the 16th of January and will run until the 9th of April. And we are consulting on, as you can see there, the use of hospital beds, planned care at the Horton. As Andrew's already explained, that hospital is based in Banbury. Acute stroke services in Oxfordshire, critical care at the Horton, maternity services at the Horton. And the consultation is in 2 phases. So if we just move to the next slide, Andrew, thank you. So this explains why we are consulting at all. So it's important to realise that our population is growing and ageing. That is good news. People are living longer. That's really, really good. We're really pleased about that. However, funding, if it stays, will not keep pace with our demand unless we make some changes. So it's important that we change the way we deliver some of our healthcare in order to ensure that our funding will keep pace with that. We need to think much more about how we all look after ourselves better. Better prevention, hopefully, will get us to better health in the long term and reduce the demand on health services. We are aware, obviously, that there are some inequalities that exist in Oxfordshire, and it's important that we try and ensure that all our population have the same outcomes from health, no matter what part of the county you live in. Quality and safety can always be better, and as a lead for quality, I'm very passionate about this area and ensuring that we really ensure that we provide the safest quality care we can, and it's important that we continue to focus on that, so things can always get better. Buildings and equipment we need. Obviously, there's some very, very specialised equipment that we rely on these days, and it's really important that we have the right buildings and the equipment in the right places for people to access, but also that we use that equipment to best effect for the population. And our other big area of challenge, if you like, is the workforce. The current workforce model is not able to keep up with the demand. So we need to think about how we use our workforce, how we use the skills of people within the service to best effect. So we're doing the consultation in 2 parts. Why is that? Well, there's a lot of services that we need to consult on, as you can see from the list that we've put up earlier. And some services needed more urgent change than others. And the Health Overview and Scrutiny Committee, which is a local authority committee that scrutinises health, as it says, suggested that we go out to consult certainly around maternity services at the Horton. Those services were temporarily closed, the obstetric services at the Horton, in October, and remain temporarily closed at this point. Critical care and stroke services were another area that we needed to consult on, as advised by HOSC. There is investment happening in the Horton, and we will explain some of that as we explain some of the different models of care as we move forward in the presentation. So, what do we think the future will look like? So our vision for the future is that people will have access to diagnostics and expert advice more locally. So that's our intention. That we will prevent unnecessary admissions to hospitals. So we know it's not the best place for people to be if they do not need to be in a hospital. That's not the best place for people to be. We need to use technology more effectively. So I'm sure all of you will have Skyped family members or use FaceTime or various other technologies in your home life. We need to use much more of that kind of technology in healthcare so we can bring the expertise perhaps out to the GP surgery, where you could have a conversation with a consultant who's perhaps based at the Royal Berkshire. So you can use technology to help the delivery of healthcare. We firmly believe that the best bed is your own bed when you don't need a hospital bed. And there's a scary statistic up there about the amount of muscle loss that happens when people are confined to bed for a long time. And we also know that if people are in hospital for a long time, they lose a degree of their independence and confidence. So again, another good reason, if you need to be in hospital, absolutely that's the right place for you, but let's try and get you home and back to your independence as quickly as possible. And I think that's the end. Lovely. I'm going to hand over to Andrew.
Thank you, Sula. What I'm going to talk about now briefly is just some of the... We're going to focus down a bit more into some of these areas that we've been talking about. Using hospital beds differently. And you know what? Henley, Townlands Memorial Hospital, has been the forerunner in this. The RACU, which opened 5 weeks ago, has been a fantastic example of what we're going to talk about. So hopefully we can explore that a little bit more. As Sula said, it's really important that people spend less time in hospital beds. And what the RACU has been able to do, as I think you all know, because many of us have it etched on our heart, is that by managing to keep care close to home, and that literally means physically close to people's homes, people spend less time in hospital. An example is an old fella who had a chest infection. This is an example from the RACU. An old fella who had a chest infection, became unwell. His GP spoke to the staff at the RACU who were able to get him up to the department. He was seen at Townlands Memorial Hospital. The doctors working in the RACU and the clinical staff could see that he wasn't well. They could see he was dehydrated and needed antibiotics. So they were able to set up a drip, give him fluids, give him some antibiotics. But he was then able to go back home to his own bed, spend the night. They got him back in the next day to check up on him, gave him a bit more fluid, a bit more care. And finally, they were able to make sure that he was able to go home safely and follow him up in subsequent days in his own home. Now, compare... This was a man who was quite unwell, and if RACU I'm getting a muddle here. If RACU had not been available, he would have had to go into the Royal Berkshire Hospital. He'd have gone into the hospital bed. He'd have become weak and dependent. He'd have stayed in bed for several days. Then there'd have been issues about getting him home, where all the care services are in place, whereas the RACU had been able to liaise closely with these services as the man was being seen in the department. So this is a real model for the rest of Oxfordshire, and it's something that my colleagues in the CCG are very excited about. This is sort of, they're already talking in Tame of providing a similar model. So I think this is the sort of thing we want to be focusing on for the future. So we should be investing more in this out-of-hospital care. It makes more sense. We don't want to be getting people into hospitals. And by caring people, not just in the right environment, but in their own environment, they get better more quickly. Thank you, sir. So we're going to spend a short bit of video.
A bit of...
Go.
You sure?
Yep.
Mum had a bit of a fall from her chair. She has dementia and she's disabled. I picked her up off the floor and it looked as though she'd had a stroke. I called the ambulance and they decided that she needed the hospital.
The Liaison Hub is a team of multi-professionals who are working together, based at the hospital, but the most of their work is actually carried out in the care home beds across the county.
Staying in hospital for the full extent of one's recovery is neither necessary nor desirable. Reducing exposure to other people who are unwell, reducing exposure to infections by moving into a hub facility increases the probability that someone's transition into wellness is going to continue without being broken up by the harms of being in a hospital environment. There's a huge psychological component to being cared for. Within 3 days, many particularly older or more vulnerable people will become incontinent, whereas previously they weren't, just by virtue of having the availability of someone to look after your most basic needs. So by expediting a transition from being in a cared for hospital environment to a much more natural, homely environment, still within the support of a nursing home or care home, then we can make sure that we're avoiding that increased dependence which a lot of patients experience. We no longer see care as being a black or white division between pure hospital care until you're fully better and then discharged home. We don't like the idea of discharge.
Radcliffe told me we managed to find you a bed in the nursing home that your wife's in. And I said, well, just thought it'd be good companionship for you, nice and be together. And I very much enjoyed it there, I really did.
I've seen really great results from people being enabled to get out of hospital, continue to have their rehabilitation and care, but in a setting that is much more homely. The liaison hub is a key component for ensuring that the whole system is using its capacity efficiently. I'm absolutely certain it's helping patients. The patients that I've worked with have really thrived.
The liaison hub made such a difference to us because actually it got Mum to the place that she really needs to be. I can't thank them enough. I'm really pleased with the way things went.
And so this principle of using our beds more wisely and getting people through them more quickly is really important to us. And I think that's really important, particularly to the frail, older people that many of us are dealing with day to day. So the next thing we're going to talk about is about, and this principally affects the situation up at the Horton Hospital. One of the things that many of my patients will ask me is, when I say to them, look, I think you should be referred to the hospital or go and have an outpatient clinic, if I tell them that they have to travel to a clinic that is 10 or 20 miles away, their heart sinks, it's a big obstacle, transport's difficult, public transport, as you know, particularly in this part of the world, is frail. And so distance from hospital is a major disincentive to care. So one of the things we're trying to do for people in the north of the county is provide more outpatient facilities, more diagnostic facilities closer to their home. Now, we already have started to do this, of course, at Townlands, but I won't keep going on about Townlands. So it's one of the things that's having to happen up in the north is expand the outpatient facilities, expand the diagnostics, because we know, particularly when dealing with things like cancer, and the investigations for cancer, the easy access to diagnostics is absolutely critical when it comes to picking up serious illness early. So by expanding the facilities at the Horton, you can see the numbers there, more people can be seen more quickly. Thank you. Stroke care. So one of the challenges in managing stroke, and this really started, I suppose, was led by work in places like London, where lots and lots of hospitals were providing stroke services all across London. And as you know, in London, there's more hospitals than I could possibly count. But lots of little hospitals across London were providing stroke services. And the problem was that some of the outcomes they were getting weren't very good. And so in London, they redesigned their stroke services to provide what's called hyperacute stroke services, where because of new treatments for stroke, which are very time critical, people could get excellent care very quickly. But to get to these services, what had to happen is that people were often driven past existing hospitals to get to the specialist hospital. Now, and that produced much better results, much better outcomes, and people recovered better from their strokes. So we're doing the same in Oxfordshire, is that previously a very small number of people having strokes would be treated at the Horton Hospital in Banbury. And we now know that that sort of service, while excellent in its own way, wasn't as good as the services that could be provided at highly specialist stroke units, such as in the Oxford University hospitals at John Radcliffe, and for that matter at the Royal Berks. So one of the changes that we're looking to make is to make sure that all stroke patients go to these hyperacute stroke units. And it's more important that it's not just the stroke itself and the treatment of the acute stroke, but it's making sure that the support people get from the recovery from stroke is focused and highly specialised as well. And so what's happening is that the CCG and the Oxford University Hospitals are making sure that these post-stroke services are all available and people get proper care after stroke. And that, again, has been really clearly shown to improve the recovery from stroke. Thank you.
At present, we have an access of all patients to the John Radcliffe for immediate assessment driven by 4 hours from onset. With the transformations that have been undertaken in stroke care in the last 18 months or so, where mechanical thrombectomy, where we use devices to pull out clots rather than just using drugs, we need to get patients to the John Radcliffe to enable equitable access from the whole county to this life-changing treatment. This is a very intensive, highly specialised intervention that very few centres in the whole of the UK can provide. And we're very fortunate that we have one of those centres here in Oxford. We also need to provide equitable access to the rehabilitation that enables the best recovery for patients. Through the early supported discharge service, which we hope to expand from the 6 postcodes it currently covers to the whole county, we hope that we will enable patients to have therapy in the comfort of their own home, enabling them to have therapy targeted and ensuring that they maximise their chances of returning to functional independence in the environment where they're going to spend the rest of their lives. And that's the whole purpose of the ESD being incorporated, early supported discharge, incorporated into this consultation. When it comes to immediate access to a hyperacute stroke unit, the major benefit to patients is the immediate assessment with specialist imaging and access to immediate specialist assessment by consultant staff, both physicians, such as myself and my radiology colleagues, where we can make the immediate decision whether mechanical thrombectomy is potentially helpful to patients. This is a decision where an immediate assessment and immediate decision really do enhance the chances of patients returning back to how they were prior to their stroke.
So the next area we're looking at is critical care. And again, this principally affects the services at the Horton Hospital. There is already what's called Level 3 critical care service at the Royal Berkshire Hospital. The problem has been that to provide a proper critical care service, a Level 3 critical care service in a relatively small hospital like the Horton has been difficult, partly because there isn't the throughput of cases to the staff can maintain their skills, and so it's been hard to recruit the staff to man these critical care services. So you need a kind of volume to make these services work. And so the proposal is to reduce or change the critical care service of the Horton so that some of the most severely ill people aren't managed there but are taken to the John Radcliffe. There will still be a Level 2 critical care. I think the proposal is there will still be a Level 2 critical care service at the Horton, but the more severe patients will go to the John Radcliffe. I think we'll move on. Yep. Yeah. So now let's talk about maternity. And I think if any of you get the Oxford Mail, or even watch the BBC, you'll know that there have been issues at the maternity unit again at the Horton. And it's the same sort of story. It's been quite difficult to staff with obstetricians a relatively small consultant maternity unit. And that's meant it's been difficult to recruit obstetricians. It's not been an attractive job for training. And as a result, it's been there's a risk that they've been trying to provide services they can't fully back up. And so on a temporary basis, that service has been changed to a midwife-led unit. And as many of you will know, there used, of course, to be a midwife-led unit in Henley, but there is a midwife-led maternity unit at Wallingford, which is highly valued and provides great care for quite a significant number of our local mums. And the proposal is to make the Horton service a midwife-led unit permanently. And similarly, special care baby services, same sort of argument. Small hospital can't really sustain the full range of services, so the special care baby unit should be at the John Radcliffe rather than at the Horton.
We want to provide a high quality, safe and sustainable maternity service. And although we provide a great service at the moment that I'm very proud to work for and work in, we can still do better. And if you look at women of today, we have sort of two groups of women. We've got a much fitter, healthy group of low-risk women, and we've got women who have more complex pregnancies. And actually, we want to design or update our service so that women can get the best outcomes for themselves and their babies and their families. So to do this, we need to look at the service that we provide and how we can make it better, make it more sustainable, and get the right women to go to the right teams.
The most important element of care for women in pregnancy and during labour is about making sure that they've got the right information to make the right decision about where they have their care and by whom. So that would be done in partnership with the woman and also her professional lead, which could be her midwife or her consultant obstetrician, depending on her pregnancy, and also her labour, her likely labour. So for women during the antenatal period, it's important that there's a risk assessment at the beginning of pregnancy to determine where they should have their care. So it would be about the right place with the right team. So if you've got a woman with a higher risk pregnancy, then there would be a requirement for them to have medical input as well as care from their midwife. But if they've got a low risk pregnancy, then for the majority of the women, they will have their care with their community midwife with some input from their general practitioner, which is also important.
The main challenge in maternity is recruiting obstetric doctors. So to recruit doctors, we need to make the jobs attractive, and we need to provide the doctors opportunities to train and to maintain their clinical skills. And currently, this is challenging, particularly in the smaller units. There's basically not enough clinical experience and clinical scenarios for the doctors to remain updated. Interestingly, there's a lot of information now and evidence that shows for these fit, healthy group of women, which most women are, they in fact do much better in low-risk midwife-led units. There's less clinical intervention and they get a much better experience and get home quicker with their babies to their families. However, for some other women, the pregnancies are more complex. And actually, as the health service developed, we've now found that these women, they do better if they're under the care of more specialist teams and have a different group or team of professionals looking after them.
Don't you love a Scottish accent? So of course, the services for women having babies in this part of the world will largely be provided at the Royal Berkshire Hospital or the midwife-led unit at the Wallingford Hospital. But of course, women do have the choice and can go to have their babies in Oxford, for example, if they wish. Sula, back to you.
Right. I think it's fairly clear on there. There are many opportunities to have your say around the consultation. So obviously we're here at a public meeting. There are questionnaires on the table and they are available on the website. So if you want to bring some for people who haven't been able to get here tonight, then please do. You can write to us at the free post address and all the information is on the website. So please do take the opportunity to look at that information. And obviously, if you would like another evening's consultation, then they're the dates of other opportunities for people. But again, if people haven't managed to get to the meeting tonight, then please do share those dates with people. And we're highlighted the 2nd of March. That's where we are in our journey. So questions?
Sula Wiltshire and Dr. Andrew Burnett, thank you very much indeed for that. All right, there's obviously a lot more detail about the proposals in this booklet, which I know is on every table. But I wonder if we've got some questions from what the presentation has thrown up here. I ought to say we did invite the local MP, but sadly I think they're on other business this evening. And various media organisations were invited as well. Any questions from what we've seen so far, please? Yes, have we got... what I'll do is ask you to use the... we've got a microphone. Is to use the microphone to ask a question so that we can have an audio recording of the whole thing. It isn't meant for any other reason than that. No questions at all. Gosh, that was a very good presentation. Now we have one. The gentleman... there we are. Yes, sir. Just use the microphone. Thank you.
Yes, Charles Langler. Step down from acute hospital has not been mentioned very much so far. I mean, I needed this 2 years ago after being in Royal Berks for 5 weeks, and I needed 10 days to get me walking. Now, how is that going to work with the beds in the care home?
Step-down bed care is actually going to be covered in the second part of our consultation. So that is something that we are going to be consulting about. You're absolutely right, and it's something I know that is something that interests a great deal, a lot of people. So that is going to be covered in the second phase. I do appreciate that this differentiation between first and second phase may seem confusing, but it is important because it's important we give everything appropriate attention. And so I absolutely assure you that step-down type beds will be covered in the second phase of the consultation.
And Andrew, when does the second phase start as well?
Well, the second phase, the initial discussions are going to start May, that sort of time.
Okay.
Yes.
Thank you. Thank you, I got it right. And then, those consultations will then run through right up until September time. That's the sort of time. So it'll be several months from May until September. Ali, have I got this right?
Almost.
Thank you.
So the actual formal consultation, so what we're doing today for phase 1 is very much the formal consultation, so it lasts for 3 months. So the equivalent for phase 2 is likely to start towards the end of the year, but there will be quite a lot of informal engagement, sort of building up the options and people having a chance to get involved with some of that through the summer and into the autumn.
Ali is the CCG Communications Supremo, is that right?
That isn't quite my title,
no,
but I'll adopt it.
Did the gentleman here with the striped jumper have a question? Yes.
Ian Reisman. I'm going to talk about the part of your presentation which covered beds. Which probably won't surprise you greatly, but you talked about the consultation which is looking at reducing the number of or the care that's given in beds and caring for people at home instead. And that's part of a whole pipeline of care where people, as Charles talked about, step down from acute into community beds and then back home. And of course, what your presentation showed was that if you can care for people at home, the need for beds can be reduced, and that can be what people want. But there is obviously a need for beds as well. But the thing that you didn't mention at all was what's completely dependent. This is a pipeline, and as soon as one section of that pipeline becomes blocked, the whole system starts to block up. And we all know that one of the main parts that is causing blockages at the moment, which you didn't mention, is that of adult social care and the services being provided by the county council. Now, there's no one here from the county council tonight. Sorry, take it back, Kate. Okay, you were keeping quiet over the corner, but so how can you reassure us that the model, which adult social care is a key part, will deliver what we need without clogging up the whole system? Because we know what's happening at the moment is that adult social care, people don't get their care packages or get them over quite a delayed period. They block up the community beds, they block up the acute beds at Royal Berks and so on, and they block up the A&E, and the whole system becomes sclerotic. And what is your consultation going to do about addressing that and getting a properly integrated service across the different sections of that pipeline, that pathway?
So in some ways, Well, it would be simplistic to say it's all down to adult social care. There's clearly multiple factors about why people don't get home from hospital and the system gets blocked up. But of course, there are many components, one of which is the availability of carers and adult social care. And I know that Kate and her team are trying very hard to deal with that. And in fact, as we know from the previous consultations we've had, there's far more social care packages being delivered in this area than there were in the past. Is that enough? No, it'll probably never be enough. I don't think we'll ever be at the position saying we've got all these carers sitting around twiddling their thumbs waiting for something to happen. So we have to try and do stuff differently. Now, one of the things that the RACU is showing, and RACU's only 5 weeks old, is that health and social care staff can work in different ways. They can work more inventively, and they can do things that, health staff will never replace the very specialist skills of carers, but by working in different ways, they can adapt to the, when there's a glut in one part of the system, there'll be a shortage in another. And by working together, you can cross-cover. Now, I know that sounds a bit glossy and simplistic, and yes, of course it is, but the reality is that what's happening in things like RACU is that we're working together much more to deal with these things.
I know Andrew Stevens wants to come in, but I think it might make sense to hear from Kate briefly as well, who's...
Thank you. Good evening. I'm Kate Taroney. I'm Director of Adult Social Care at the County Council. A couple of points. So it's the first time I've seen some of those video clips today, and really interested to hear the comments around the liaison hub that's currently working from the John Radcliffe. The Liaison Hub is a perfect example for me where we have social care staff, we have occupational therapists, we have medical clinicians working together to support people out of acute beds into nursing home beds around the county so that they can move on in their journey either back home or to a long-term placement. So we've got some nice examples already where by bringing our staff together and by thinking collectively about how we target our limited resources to help people flow out of hospital as quickly as possible. I think that's a good example to look to. We've got other things such as the County Council and the Clinical Commissioning Group commission a home from hospital reablement service that's provided by the acute sector. And again, that's a really important way of ensuring people leave hospital and they don't automatically go into long-term care, but they have some time at home to get back their independence up before we find long-term care if that's what's needed. The question you asked is going to be particularly pertinent for Phase 2. So Phase 2, when we start thinking about what are the configurations of some of these other things, including step-down beds, ensuring that the right resources in social care, the right workforce, etc., is going to be critical to making it work. So it's absolutely key for the Phase 2 part of the conversation as well.
All right, Kate, thank you very much indeed. And also, Andrew Stevens, he's the Director of Strategy and Planning at the Oxford University Hospital NHS Foundation.
It's really just to reinforce what Kate has just said, that we are already learning from some of the good examples. PACU is in some ways pioneering a lot of this work for the rest of the county, but also the examples you've heard of the integrated hub, the service that we as an acute trust provide that's commissioned by the County Council are giving us good insights into new ideas and new ways of organising our care. But I think staffing around some of the domiciliary care, not just in social care but in health, is going to be one of the key challenges that we're going to face as a system. And so I think it's right to put that challenge to us, and it's something that we are going to have to address in Phase 2 collectively.
Any further questions? Yes, sir.
At the stakeholders meeting on the 24th of January, it was said that there was one place vacant in the care home only out of the allocation. Now we're getting 400 more houses in Henley, plus everybody in their town's getting older. I've really got to say somebody at some time or another has got to readdress whether we do need more beds.
Okay. I think that's, yes, probably better with Kate to deal with again.
So if I can give you a broad stat, and it may not be exactly to the number, but there's something like 4,600 residential and nursing beds in the county. And at any one time, there's between 100 and 200 vacant beds. So the team that work for me, we've got a kind of placement sourcing team who are constantly looking for vacant beds to support people to move into when they need residential or nursing care, are targeting those vacant beds. That's not to say sometimes there are still delays supporting people into a residential or nursing bed because it might be about that individual's needs and where their family want that person to be moved to. That can sometimes affect the speed with which people can be placed. But I do not believe there's ever been an occasion that I know of where we've got only one vacant bed in the whole of the county. People, yeah.
If your wife wants to come and visit you and she's perhaps 5 years' time, 80, she's not going to want to go to the other end of the county to visit you, is she?
Yeah. I mean,
you live in Henley, which is a big town, which is going to increase by 400 houses. Now, goodness knows how many more people that's going to be. When I came out of Royal Berks, I was sent to Wallingford.
Right.
So having spent 5 weeks coming to visit me in Royal Berks, my wife had to do another 10 days to Wallingford. You know, we're a big enough town. I'm just saying we've got to obviously see how it goes.
Charles, it's Pete McGrain. I'm the Clinical Director for Older People Services with Oxford Health. So we're the provider arm, and I know many of familiar faces from our many discussions about bed-based care within Townlands. I think there's a couple of things, observations that I would make upon what you're saying. None of us are stepping away from the challenge that we've got about when we appropriately use bed-based care for rehabilitation and what it is that we can do in terms of delivering rehabilitation with the same, in some cases, improved outcomes for patients, but by doing it for patients in their own homes. Now, I'm going to give you an example. So, reablement services, which have been delivered across Oxfordshire for a number of years, commissioned by Kate and colleagues within adult social care. And it's always surprised us that patients who've been in a bedded setting in hospital care, be that in a community hospital or be it within, as Andrew and colleagues within the acute or in the Royal Berks, Andrew's colleagues in the John Radcliffe are within the Royal Berks. When we got those patients out, we would have had an anticipation as to what their care needs would be. And we wouldn't have anticipated what length we think that we would need to be involved with those patients in their own homes. And frequently, probably more often than not, I think it's about 72% from memory, but it's gone back a little while now, we find that patients done much, much better and rehabilitated much, much quicker when we got them into their own homes. And we find that we were often doing... No, hold on a second, Charles. Because we often find that patients were doing better than we had anticipated. Now, there is always going to be a requirement for bed-based rehabilitation. Andrew Stevens and Kate and colleagues have been doing remarkable things in terms of what we're doing to support patients with rehabilitation through a broadened use of residential homes and nursing homes across the county. And we will have to learn the lessons from that. I'll be frank, I've said this before in public events, I was a sceptic as to whether this was going to work, and I've been a complete convert because it has helped. It has changed things around. And we will have to learn from that and use that bed base more. And if to go back to what we're doing in Raku, we're 5 weeks in. We're about 32 patients. This week, 32 patients from this area have accessed care within the Raku services within Henley. Those are patients, over 40 individual patients have been treated in Henley where admission has been prevented. And for those patients who we've had to step up into a bed in the care home, the intensity of what we're delivering there now is much greater than we were ever capable of delivering within Pepard Board when it was there. And the average length of time that patients are spending in those beds is 5 days. The average length of time that patients were in a hospital, in a community hospital bed before we had those services was 32 days. So I think we have to see that we are on a journey and we are changing, and the whole nature of the model of what it is that we're doing is changing. But when we get into the phase 2 of consultation, these very discussions will be at the heart of how we shape new models of care to support that broadened patient population.
All right, there's a lady behind you that I'll come back to you if I can later on, but there's a lady behind you who's had her hand up for a while.
I respect what you've just said, and I can understand that and go fully with it. However, as Zula said in her opening introduction, not only do I recognised from this gentleman that Henley is expanding. So is Sonning Common and a lot of other villages around. And we are expanding in population and age living. Sula? So therefore, you are going to have more people requiring the step in, step out, step up, step down, whatever, care. And you're not going to provide it. You're not going to meet the needs because there are no beds and there are no facilities. You can't. We need perhaps another RACU or a bigger one or whatever.
All right. Sula, did you want to address
that?
Yes,
well, if I make a start and then please feel free others to... So, despite...
What we didn't get, your name. Sue, from
Sonic. So yes, the population is expanding, and yes, there is population growth, but it's unlikely that everybody's going to need care at the same time or age at the same time. So there'll be a gradual process whereby we will continually change health services. It will evolve. I mean, it is one of those things that it doesn't stay static, as we've shown through some of the videos tonight. The care you get doesn't stay static. The way we deliver care will not stay static. And I think it's highly unlikely that, if you like, all the 400 houses or whatever number of houses it might be will all require the same level of input from healthcare. But obviously we do participate in the planning of that healthcare. A lot of that healthcare is likely to be the primary care end of healthcare. And again, we're not discussing that at this consultation, but we'll be talking about primary care in the next phase, because often what people need at that stage is, if you like, keeping them well rather than the illness side of things. So it's complex, absolutely acknowledge that. And there is a great deal of thought given to the amount of housing that's been built and the needs of that population in relation to health. So it is something we are looking at. And do you want to add, Andrew?
Well, if I may. I think you're absolutely right that we are faced. It's not really the new houses that are the problem. It's the existing people in the existing houses that are getting older. And that's because... It's partly because the success of the health service, that we've already alluded to, not just health services, but better social care and better nutrition, and people are better housing. People are living for longer. So, but I'm doing my Donald Trump here. I hope you're noticing. What this is showing is that as the population ages and therefore has greater needs, but we have to meet it in a different way. And that's why we're holding this consultation. Yeah. And a lot of it will come into phase 2. But the important thing is that we think, how can we do things better? So Pete has given a great example of, people used to have an average length of stay in a hospital bed in Townlands for 32 days and have rather low-intensity care. So now what we're doing with the beds that we're using in the care home is the average length of stay is 5 days. Well, you can see, therefore, that you're getting 6 times the value out of the bed. And in fact, of course, when people were in those beds for 32 days, they were deteriorating. And this thing of the loss of muscle strength. So by speeding up this process, this much more intensive rehabilitation, we're providing better quality care. Beds everyone gets hung up on beds. Beds are a fairly minor part of the equation. What's important is that we're treating more people in the same resource. And as you know, as you may remember, RACU isn't a money-saving thing. It's costing about the same. But we're treating far more people in it. Therefore, the outcome is better. So I don't want to kind of blow...
How soon after you've been in RACU are you expected to stay out before you need it again? Any ideas?
Well, it's too early to say.
Exactly. But do beware that we need you to think about the future as well as the present.
Sure, of course. And we'll have better figures by phase 2, if I can say that. I mean, it's an important point, but that so far, at the moment, that's the position. But by phase 2, we'll have more experience of RACU. But it's not just about RACU. RACU is a kind of relatively small part of what's happening in Oxfordshire. These very exciting things about the rehabilitation, the liaison hubs that are running elsewhere. And we're trying to replicate that. Remember, what we're doing here is we're talking about what we're trying to do across the whole of Oxfordshire. And it's trying to replicate that better provision, more joined-up thinking, more joined-up care.
There's a gentleman at the back there on that table.
Hello, I'm Philip Unwin. I'm one of the GPs here in Henley. I work in the intermediate care bed bit of the new system. And I think, I'd just like to say I was a bit of a sceptic when we started out on this journey as to whether it was going to work. I think we can all say that we have the most amazing hospital for a town of this size. It's the facilities it provides and the people that work there are quite extraordinary. So I think the team who put that together should be congratulated. The RACU system, I was a bit sceptical to start with, but I think I've used it as a doctor and referred patients there and found it incredibly helpful. It's efficient. There is capacity. You can get people in, seen. My partner Michelle had just written me a note about the transport, how we're going to organise transport to and from it, but that's something that I'm sure is a logistical thing that can be sorted out. And I want to just remind everyone that we've got in the care home, we have 2 types of beds. We have both the RACU beds, which are referred to by the RACU doctors and are for their use and are being used carefully, I think it's fair to say, because they are sometimes not in use, and in which case we use them for intermediate care beds, so there's full usage there. And that is the third type of care that's being provided here, the intermediate care beds. And it's not a perfect system, but it's getting better all the time. And I have to be really honest with you. I did my ward round there today, and of the 9 beds or 8 beds that were there, 5 of them have patients in it waiting for social service care. Now, we've tried to escalate this a little bit, and I suspect something, and I don't want to preempt what you're going to say in the second part of your phase 2 of your consultation, but and something may be planned, but at the moment it is the thing that's clogging us up. 5 out of the 7 or 8 beds have people there. 2 have been waiting over a month. And that's a shame because the system, I believe, is good. I think the balance is right at the moment in terms of numbers of beds, of RACU beds and the RACU service. I think it's an exciting project, and I think it may well work really well. But we've got to make sure that at the end of the day, at the end of the system, there isn't a blockage that's stopping it really functioning well. And maybe that is planned. I don't know, but I expect we'll find out when phase 2 of this consultation is.
And can I just ask you, what are the bits that have surprised you the most that have worked well then? You said you were cynical at the start.
Yeah, I was a little bit because everyone was fond of Peppard Ward and the good work it did. But we did treat not very many patients for a long time. That was the problem. Yeah. And so something I felt did need to change. And when this new system came up, I thought it was an exciting idea. And I have to say, I've used the new system. And it does work fantastically well if you're that sort of patient, if it suits you. And that is someone who can be treated as an outpatient or as a temporary inpatient in one of the new RACU beds. And I found they were very efficient. They're well staffed. They're well equipped. They have good equipment there, and it's a fantastic service. But ultimately, we do need the throughput of patients through the whole system. And if there's a blockage at the end, we have to find a way of getting rid of that blockage.
It was this gentleman's point.
Yeah, and I get that point totally. I think that's absolutely correct. But I think the system, the difficult stuff is in place now. We've just got to be positive about what we've got and do everything we can to make sure that that blockage does not occur. And we try very hard at the intermediate care bed end of things to make sure that doesn't occur. But I think, the future's bright. I think we've got some, I think we're very, very lucky to have the whole system here for our use.
Got some nodding heads of both the panel and the audience, I'm pleased to say. The gentleman with the strap. Were any of the ladies at the back wanting to ask anything? No, gentlemen at the. Sorry, I'm not trying to avoid you.
I'm very happy someone. Just to come back on Phil's point, I haven't talked to Phil recently about since the RACU opened, but I have talked to other GPs, and they say exactly the same thing as Phil. That yes, there was a degree of scepticism, as there was in the community generally, but the scheme is working well, with the proviso, the very significant proviso about the difficulty of getting the care packages so people can return home and not get their transfer out delayed. And that, I wanted to move on to the point both Pete and Andrew made about the new model and the way it is an improvement. And it's clear that there is certainly potential for improvement, and there already is some evidence that what we have here, we're very fortunate to have a great new hospital with a service that has a great deal of potential. But how, in say 3 or 5 years' time, are we going to turn around and say yes, or even a year's time? How do we know that the new model is working, that it's successful? And I want to suggest that you measure the right things. Measuring the number of days people stay in a hospital bed should not be the goal. The goal should be measuring health outcomes, whether patients get better care, whether their health is improved, whether their lives are improved, whether the length of their life is improved. And how are you going to measure that? And how are you going to show us that this new model has worked, and that can be, and as you say, Henley is something of a pilot, and that it can be used around the county, around the country, to provide similar benefits for other people?
Well, and I think this is a question that is being dealt with by the liaison group that already exists. I can't really tell you the answer at this meeting. I agree that it's not all about how long people stay in hospital. I mean, you could say it's almost like a supplementary or a false endpoint, because we know that the longer people stay in hospital, the more unwell they become. So that's as close as I can get to it. And also the sheer numbers of people that are being treated has gone up. Now, from the CCG's point of view, if you think what costs money, it's having people in hospital. So the CCG, in terms of managing our resources properly, want to make sure that people don't stay in hospital unnecessarily, partly because it costs less money, but also because clinically it makes sense for people not to stay in hospital too long because it's not safe for them. Hospitals, bizarrely, are very unsafe places. So we want to get people back in their own homes very quickly. How do you measure the success of the RACU? Well, there's already measures going in, things like patient satisfaction, relative satisfaction, meaning satisfaction of the relatives, and we're going to look at the admission rates to the Royal Berks Hospital from this area as well to see if it's made a difference in that. I don't know, Pete, if you want to add any more to that.
So I would agree wholeheartedly with what you're saying, Ian, in terms of measure the right things. There's nothing. We're providers of services. Sula and colleagues are commissioners. And Kate and colleagues likewise, commission services from us. And we've been doing a huge amount of work together in terms of trying to make sure that there's an optimum balance between what you measure in terms of the process things. Because with the best will in the world, Ian, you and I both know that we sat through a number of meetings and a number of consultation events, and so you'll have been at those as well. And the public were particularly interested in both those things. They were particularly interested in what the outcomes are for patients, but they also wanted to have the mix of what we might call the process things. How many patients? How quickly? In what place? And we need to get the optimum balance so that we're not counting beans, so to speak, all the time, but that we're trying to understand what the outcomes are. And Sula and I have been in, with colleagues, have been in discussions most recently about how do we develop a tool which is gets us the best indication about what are the functional improvements that patients see through rehabilitation in our care, where that care passes across a number of different domains, some of it being inpatient and some of it being outpatient. And when we get into our phase 2 consultations, one of the things that the public are going to say to us is, well, how do you know? And what's the evidence that underpins the assumption that you make? And the difficulty is that in some cases we're running to try to keep up because a lot of the changes that we're making to the healthcare, we haven't got a firm, very firm evidence base for it because they haven't been studied longitudinally in big sections. But we know that it is what the public are telling us that they want from healthcare. And we know because our clinicians are telling us, our best gut feel is telling us that this is good and gives us good outcomes for patients. And we have to make sure that we develop systems that enable us to be able to give the measurements, but that will come over time. So sometimes you will have a good answer. Stroke, you saw from the video, Professor James Kennedy, there's an abundance of evidence from long-term studies about the benefits that you get from early supported discharge and from treatment in a hyperacute stroke unit. That doesn't exist when we start to get to a lot of our community-based services. It is an evidence-free zone, and we are in the process of developing, with our academic colleagues in the Academic Health Sciences Centre, right across the region, how do we get systems that enable us to do that? But there isn't a perfect answer to this, Ian, but you're absolutely right to point it out that we get the best balance, and that's what we as providers want.
And, of course, this is a consultation, and there are various ways, as Sula had already outlined, on the back of that form, but also on the back of that. So consultation doesn't end at the end of this meeting. There are other meetings, but it also doesn't necessarily stop just when the consultation of the last meeting finishes. There's that time period to get in touch. I know you want another go. There's just the lady at the back who's put the hand up, and I'm keen to hear from as many different people as possible tonight. You're kind of hiding at the back there, but I know you've got a...
No, I'm not at all. We're hearing about evidence.
Could you hold it closer in? Thank you.
We're hearing about evidence at the moment. This meeting has been called to consult on changes that have already happened in our area and in Oxfordshire as a whole. Community beds have been closed. The Horton Hospital has been downgraded. The Townlands Hospital has been downgraded as well in that sense because it's half empty and the RACU is there. What I want to know is, I agree with what Ian is saying about how will we know that these systems, new systems are working. The fact is that these changes are delivering the 5-year forward view which the government initiated, or NHS England wrote, which introduced new models of care, of which the RACU and hubs and so on are examples. Meanwhile, that was 2 years ago, and as a result of that, without consultation, our hospital in Henley was downgraded. Community bed, it was decided that we didn't need any beds there. That's one example. What I want to know when we're talking about risk assessment is that these changes are already taking place all over Oxfordshire. Particularly in the last few months, we have been talking about the sustainability and transformation plans that all areas of the country are have had imposed upon them. These plans have now been made public, but the changes that have been happening over the last 12 months in our hospitals, in our localities, have occurred. What risk assessments were there, or where is the evidence, or where are the risk assessments to show that closing community beds, downgrading hospitals such as the Horton, cutting the beds at the JR, and I'm not even mentioning the Royal Berkshire Hospital, but that's because we're not even allowed to talk about the Royal Berkshire Hospital at the moment. But where is the evidence that it will benefit, any of these changes will benefit the health? Where are the risk assessments? Why aren't they published?
All right, so
they should have taken place.
Okay, so two strands to that question. The first is this a consultation and are you listening? And the second one was then about, effectively, the risk assessments involved with that. Andrew?
Yeah, so if I kick off, it comes back to almost the discussion we were having about beds and how you, measure the benefits, the level of care that you're providing, and using beds as a proxy for that, because I think that's wrong, and I think it's old-fashioned. And as Andrew has said, as Pete says, as Kate has said, we've got to get out of that. We've got to find better ways of measuring, because I would, and our Trust Board would very much disagree with the fact that we are downgrading the Horton. We think these proposals that we're putting forward are about a positive and vibrant future for the Horton. Yes, it's different, but it's absolutely, as a result of these, 90,000 more patients from the area served by the Horton are going to be seen locally rather than having to travel to Oxford. That's got to be a good thing for the local population. As I say, we do not believe we're downgrading. Each of the proposals, so if we put the beds to one side for the time being, if you look at critical care, if you look at stroke, if you look at maternity, all of those are being driven by issues of clinical quality, of clinical safety, or clinical sustainability. And we believe, and I think the $64,000 question in my mind would be, if money were no object, would we still be doing these changes? And the answer is absolutely yes. Because for stroke patients, there is clinical evidence out there, as Andrew referred to, that the model of care that is being proposed provides better outcomes for patients. More patients will survive a stroke, and more patients will survive with a better outcome and a better lifestyle following that. So that's the stroke. Similarly, for critical care, if your clinicians are seeing less than one critical care, level 3 critical care condition a week, are they going to be able to keep up their skills? We don't believe so. So in terms of equity of making sure that the people in the north of the county have access to that high level of quality of service, we think it is absolutely right that they should travel to Oxford. Yes, there is a loss of geographical access, but we think that is more than outweighed by the clinical benefit. Likewise, there was a full risk assessment done for maternity, and that is on our website. It's part of the evidence that is informed these proposals. It formed part of the paper that went to our public board. So if you go on our website and look at our public board meeting for the 31st of August, you'll see the risk assessment that was done, that the board concluded that could we run a safe service at the Horton, a safe obstetric delivery service at the Horton without the required doctors? No. Was it safer to move to a midwifery-led unit? Yes, it was. And you heard from Veronica Miller, one of our consultant obstetricians, and we're already, as we've said, running 3 very much valued midwifery-led units already that says that you can run a safe midwifery-led service for low-risk births. So I would contend that all of our proposals are driven by considerations of risk, of quality, and clinical sustainability.
Yeah,
Sula.
I would absolutely support what Andrew has said. Where the evidence and the research has told us how to manage patient care more effectively, it's our duty to ensure that that happens. So in relation to stroke, we know that if people spend time on what's called a hyperacute stroke unit, are seen quickly, the outcomes are better. It's absolutely driven by the evidence. The work around the midwifery-led unit, we do monitor that very carefully in the period of time where we've temporarily closed the obstetric unit. If I could just say the consultation, we are interested in your views and comments. That's why we're here. We are listening. We can't obviously guarantee that every view that everybody offers will result in their perspective. What we've got to do is try and gather all those views together, understand them, and then with all the other pieces of information, i.e. the population needs, the clinical evidence that we've got, try then and come to a decision. So we are listening. We do want to hear your views. I think the language, if you like, around so the lady referred to the STP, the Sustainable and Transformation Plans. So I think they are across the country. You're absolutely right. There are 44, and we're in the 44th footprint. Oxfordshire is a part of that. So it's Oxfordshire, well, it's Buckinghamshire, Oxfordshire and West Berkshire, and it's called the Bob footprint locally. And Oxfordshire is a key part of that. And this is, if you like, our local piece of that jigsaw, if that makes sense.
Okay, thank you very much indeed. Do you want to, yes, do you want to come back?
The STPs,
sorry,
as everybody knows what the STPs are now, if they didn't already. These plans were also predicated on making, I think it was £30 billion worth of savings by 2020, and the new models of care, which we're talking about tonight, are a means of delivering those savings. That is unquestionably the point of those NHS England reforms, reconfigurations, which we are talking about tonight,
but there
to
is nobody
save
from
money.
Okay, but there's nobody from the government or NHS England overbody
yes,
here.
but you are the leaders of this programme, and therefore there is some accountability there, isn't there?
Is there a question locally that you want to?
Locally. Well, I mean, we're supposed to be saving money, and we've got a hospital that is a hospital which we're paying vast amounts of rent for, and it's empty. How much money is the CCG paying to keep open an empty hospital or a half-empty hospital? How much is that costing the health service?
Which hospital are you referring to?
Townlands.
Oh, Townlands.
Well, I'm sorry, Veronica, I don't have the exact figure in my head, but clearly it's costing money. But this is part of this. This will come into phase 2 of the consultation, the community hospital beds and the community hospital use of community hospitals. It is definitely going to be consulted on. The CCG, I know, and the NHS Property Services, who have the ability, are trying very hard to use the facilities available. I'm aware of a couple of things they're trying to do, but I can't talk about it at the moment. So, it's something. It's certainly an important topic, and you're right to raise it.
Okay. Any further questions? Yes. Just hang on a minute, Phil, and we'll get there.
On the STPs, Veronica is quite right that the Bob STP, at its introduction, it identifies £479 million worth of cuts that have to be delivered by the STP by 2020, because that is the deficit which has to be eliminated, and that's what every single area of the 44 areas is being asked to do. And if you look at the front of the questions for the consultation that we have, the second bullet point says very clearly: general acceptance that change is needed and that there is not enough money to meet rising demands. Now, what there isn't is enough money that's being provided by the government, and the people running the STPs and the CCGs are having to cut the cloth of the NHS services according to what they've been given. And we should recognise, and I think this consultation should accept that what we are seeing here is a response to the lack of funding that central government have been introducing, and the SDP, of which this is part, is an exercise in saving money.
All right, well, sadly we don't have the local MP here, but we do have a colleague within the NHS who will just, if you better just put your name on to the audio record for us.
So I'm Catherine Mountford, one of the directors at the CCG, and Ian has probably made many of the points I wanted to make. So NHS finances, I think, just to reiterate what Sula said, we are getting more money every year. So NHS funding is going up each year, but it is not going up as fast as the increasing demand and the amount of things that we can do. So as Ian says, what we're having to do is, as a CCG, it is our duty to live within the amount of funding that government gives us, and that whole process about how much the NHS gets, as Gavin said, is a government decision, and we can all influence that as individuals, but our job as an organisation is to use what we've got to best effect. And what we've been trying to explain and talk about tonight is we think there are new models and new ways of doing that. And as Andrew talked about, the RACU is seeing more people with the same amount of money, and that's what we've got to continue to do. So the savings, the NHS is slightly strange in the way in which it talks about needing to make savings. We say, if we didn't do anything and the demand carries on going up, how much would it cost us? How much are we going to get, and how do we close that gap? So it's about how do we recycle and reuse the money that we've got.
All right, thank you very much indeed. I'm reluctant to get into a sort of national political sphere because I don't think it serves the purpose without the MP or a government minister here to sort of do anything about that. Any more questions? Yes. Right. We were drifting back onto the national bit again now here. But
what I'm saying is that we're told we have the power here locally
all right.
to decide.
Okay.
We should be giving our views.
Well, I think you've made that clear. Yes, there's a gentleman, and it's back to you, sir.
Charles Langler. I don't want to end on a negative note, so I'll be positive. I agree, we've got a marvellous hospital. It's vastly different from what we thought it was going to be 2 years ago. Or 10 years ago, when we thought we weren't going to have a hospital at all. We're marching around the town protesting and delivering petitions to Downing Street. So local people have done a lot of work. I think we've edged you towards something that's now working. But I still, there's a concern. Having been through what I went through, and I don't know how many of you have gone through the sort of sickness and recovery that I have, there are reasons why you need people for sometimes to be 10 days in hospital to get you walking again, to get you home. And I'm not sure how well this will cope with that sort of thing.
Okay. To be fair, I don't think anyone suggested there aren't going to be those needs. But
I absolutely agree. There will always be a place for rehabilitation care, and that's we're not denying that. We have to make sure, as an Oxfordshire organisation, that we provide that across Oxfordshire. Whether we provide that in every small town in Oxfordshire is, of course, difficult to do. But there has to be that sort of care available as part of a package of measures. There'll be some beds will be needed. Some beds won't be needed at all. Some will be needed for rehabilitation care, and some will be needed for the sort of care that Philip has described. So, I think all your points are fair.
Yeah. Okay, any final thoughts? Well, don't have to be final, but it sounds like we're drying up a little bit. Okay, well, in that case, what would you like to do, Ali? Call it a day, if anyone's got any last bits to say? Yeah. Yes, that's a good idea. No, then that'll put everyone in the picture.
Okay. Well, we're going to have a couple of people leaving now. I think we should say thank you to those people who've come tonight, but to recognise it has been a very much smaller meeting than we've had at other places. So I think it's been fair to allow the question and answer to be managed in the way that you've done it. Thank you, Gavin. So what we've done today is to keep a note. We've recorded the whole meeting, but we've also been taking careful note of all the questions that you've asked. We are posting all the questions on the website, and you'll find also an audio recording of all the other meetings, and this one will join that in due course. It takes us a little bit of time technically to get that organised. And the consultation is open until the 9th of April. Some of you, if you prefer to complete the questionnaire on paper, we'll happily take that. You can leave it here with us tonight, or you can post it to us, or you can complete it on the website. Then we will be pulling together a report of the consultation, and that will include a full analysis of all the issues that have been raised, not just through the survey and the meetings, but through the various letters and emails. We've also been out to a number of other groups and communities who've wanted to come and talk to them specifically. So we'll have a report available towards the end of May, and it will also be discussed at the CCG board meeting in its May meeting. And anyone who wants a copy will find it on the website, and if they want us to post one to them, they need to leave their name and address with us.
And of course, people can take these home with them, and that's got the details of the CCG and how to get in touch on the back. Yes. But if there are no further questions, our next meeting is at Wallingford on Monday at 8 o'clock. Thank you.
Thank you.